Hey guys, welcome to the Dr. G Show. This is episode 191.
191. Woo!
I know, almost to 200.
Man,
I gotta figure out what I'm
did
gonna
a
do
lot
for
of
200.
shows.
5 years.
Man,
5 years.
way to keep it consistent.
Yeah. See,
Yeah.
it's the one continuous thing. See, commitment.
It shows commitment.
I'm all about commitment.
Mm-hmm. Some
5-year
people, it's
commitment.
the Chiefs. Some people, marriage, and others, it's live feed.
That's right.
Good job.
So today we're going to talk about depression, and this is part 2. So if you tuned in last week, it was through event, and I posted on the page. There was quite a bit of vulnerability and self-revelation that I went through to kind of, lead with transparency. Because I know it can be a very difficult subject for a lot of people. And hopefully today we'll kind of offer some hope and some tools and techniques and things that will really help turn things around very quickly for you, hopefully. The last 2 episodes we did before that was on anxiety, and so we're going to touch a little bit today on biology, life events, individual factors, therapy, and then kind of mindfulness practices and dialectical behavioral therapy maybe. So before we get into everything, we have a stranger danger among us. No. And this
Very
is
dangerous.
my mentor when I was struggling at my worst. Scott had started a mindful group, and I joined it, and it totally revolutionized my way of thinking. And it just turned life around to where I thought I was happy before, but I was really coping very well. And even with patients today, I still ask, are you stressed? Oh, no, I'm not stressed. All right. Are you stressed and just coping really well, or do you really not have stress? Oh, I cope really well, kind of thing. Yeah. So before, oh my gosh, sorry.
You're getting a call. Better decline that one.
Dr. Venke, Dr. Venke is trying to call me from Thailand.
From Thailand? Oh,
yeah,
wow.
yeah. He's an awesome medical doctor up there that presented papers and at the seminar I spoke at. But he's trying to call me because he wants my help with some stuff. But sorry, you had to wait. You guys are more important. Oh, that's not true. No, don't. If he hears that, that's not good.
You just all things in their correct order.
There you go. See,
right.
That's why you're the guru. So, Scott, I'd like you to kind of introduce yourself, kind of what you do, and all that.
Yeah, can sure do that. Well, thanks for having me back, Patrick. And we've been friends for how long ago was that we met through?
5 years.
5 years already. Wow.
Yeah.
How about that? So much has changed.
Right.
In all that time.
You got married during that time.
I got married. I cannonballed into the deep end of family life. Now I live with 4 children and my lovely wife, Mariah.
I'm the last remaining bachelor, you know that, right? Everybody else from our group is in relationships or got married.
Interesting.
Yeah.
You're a real holdout, aren't you?
I know.
He's committed to being a bachelor as well as his
life.
Just kidding.
I'm committed to finding love that I can drown in.
That sounds really poetic. Look at that. So anyway, my name's Scott Spradlin, friend to Patrick Garrett, and glad to be here. We met through a mindfulness meditation group, which I was facilitating a number of years ago, and that's when I had the pleasure and honor of becoming friends with Patrick. I'm also a licensed professional counselor. I am a licensed master's addiction counselor here in the state of Kansas also. And I engage in telehealth therapy, providing dialectical behavior therapy, or DBT, which is a mindfulness-based, principle-centered, evidence-supported psychotherapy to treat borderline personality disorder and other issues that people have where there's profound emotional dysregulation, anything that we see kind of escalated behaviors, everything from suicidality to compulsive self-harm or other things like ADHD and addictions and so on. So that's kind of my jam.
Yeah.
That's what I do, and I love it very much. I'm going on 22 or so years in my field. Yeah.
I didn't even think you were 28. What is that?
I'm a couple of days over 28.
when we were a mindful group, we'd all introduce ourselves, and I'd always introduce him as I'm his oldest son.
You've always been like a father to me, Patrick. Actually, that's what he would say to me. You've always been like a father to me.
You've always been like a father. So, depression's a hard thing. I'm pretty jovial about everything because life really is not all that crazy for the most part. And so, but people end up in these situations where, especially, like in my practice, I do mostly like superficial kind of like depression stuff and anxiety and kind of help people out with just easy things that they're, I always call white people problems, but just kind of like, life's events or just whatever. But you guys deal with the hard stuff. And Scott, you've dealt with some of the hardest kind of patients because you dealt with drug addicts, right?
Yeah, I've done a lot of work. I worked for a couple of years at a local methadone clinic where I was implementing DBT and mindfulness-based practices. Patients were wonderful. They really ate it up. Also, an outpatient substance treatment centers here in town.
Yeah.
I've done that. And I was going to say, too, I wanted to mention in there and put it as a shameless plug that what I do is for my present practice is that I'm also in cahoots with my wife, Mariah, who's also a licensed clinical social worker. So we're kind of in family business together now at North Star
That's
Therapy.
nepotism.
Nepotism. Anyway.
He always wanted to get on that practice, and so he couldn't figure out a way in, so he married his way in.
I just thought if I married Mariah, if I could marry her, because she was way open to that before she was letting me come into her practice. So you're on to me. You figured it out, and she's going to watch this, and now she's going to know. I love you, honey. Really
so between like the patients I see and the patients that you see, like hopefully we can come up with some good ideas for you guys. Tell us a little bit before we start about DBT, because he was not only my mentor, he was my professor, because I took continuing education hours through you.
Well, that's true. You
on
did.
dialectical behavioral therapy.
Yeah, you've got some hours in training in DBT. That's right.
Yeah.
DBT is short for dialectical behavior therapy, which is why we prefer to say DBT, because it's quite a mouthful. It's a therapy that was developed by Dr. Marsha Linehan, going back decades, in her work and research with folks that were considered to be some of the most, treatment-resistant to psychotherapy, borderline personality disorder, actively suicidal individuals. And over the years, long story shorter would be that she cracked the code through painstaking research and modifying treatment, cobbled together an integrated model that became DBT, utilizing, again, mindfulness training, distress tolerance skills, emotion regulation, which is something we'll probably talk about a little bit tonight because it's germane to any of us dealing with anxiety, depression, and stress and physiological effects that those things can have on us. Also interpersonal effectiveness skills, and then self-management, relapse prevention. The gold star standard DBT that the research supports as being efficacious for treating BPD and other related disorders includes one-on-one weekly DBT therapy with your therapist, DBT skills training group once a week for 2 hours for a predetermined length of time that's limited but renewable, and also a phone consultation with your therapist between sessions to do kind of non-urgent, non-crisis oriented coaching to help you generalize, or I should say first to acquire skill where you really need it in your natural environments, and then to be able to generalize them into all the relevant domains of life where we really need them. And then the therapists themselves participate in a DBT consult team to make sure that the patients we treat, it's therapy for the therapist, but it's also our way of helping one another stay in that model, so we're not just kind of like spiraling out into Scott's most recent crazy idea about therapy.
Right.
Yeah, we can kind of reel it in, or if we're feeling burned out. It's a great therapy. I was trained in Portland, Oregon, finished my intensive training with Dr. Linehan in Seattle, Washington. It was really amazing. Been a big conversion experience to the therapy, and I've been practicing ever since. I love DBT, but I love Mariah more.
So used to we have Holly Hajajana on the show.
That's right.
And I would talk way out here about stuff, and then she'd be like, reel it back in, right?
Right.
And you're the only guest I ever have that talks so far above what I even know conceptually. Yeah? And you use words like Jermaine, and I'm like, Michael's brother? Nobody's going to get that joke.
Okay. No, Jackson's.
But, yeah, so you remember, so you know how I explain it to patients when I refer?
Oh.
I say...
Oh, okay. How do you do it?
So I remember it from him. So that there's diachronious thinking. You correct me if I'm wrong.
Dialectical.
And dialectical.
Yeah.
Diachronious is basically you win or you lose, and most people are just going to lose all the time.
Right.
So it's like, I'm going to lose 30 pounds. And then if you don't lose it and you lose 29 pounds, you are a failure to yourself, right?
Right.
But dialectical is more of like, I want to get healthier, right?
Mm-hmm.
So then no matter how much weight you lose, you win.
That's right.
Right? So dialectical and versus diachronious thinking is, to me, is like always win, and almost always fail. Yeah. Or set yourself up for failure.
Right.
And then the three parts that I always tell patients is dialectical behavioral therapy is become aware of what's not working, make mindful changes, and practice those changes. Is that right?
That's a great beginning.
I had a good professor.
That's really good. That's really good.
Is that right?
Yes, it is. And part of what we do, no, it's not. It's a great start. Then you can, as they come see me, and then we can just sort of bake their noodle some more, and slowly, dialectically help them grow into a more comprehensive understanding of all of that. Yeah.
I wish I could speak as eloquently as you do. But I was educated in Texas.
Ooh.
And we're 45th in the nation, so I can barely spell or read.
Okay, really?
I do know how to synthesize the methylated alkaloid, though.
You got me on that one.
So there's that.
In my face, I got to say.
All right. So whatever I don't know tonight, and whatever I mislead you on and take you down the wrong trail, Scott is here.
I'll try to counterbalance that, and likewise, because I may have some things that we'll probably talk about related again to physiology, because there's some ways you've actually influenced my practice, Patrick, just so you know. The language that you use, because I don't treat just folks that all need comprehensive DBT, but sometimes DBT informed. But definitely all my practices with therapy are mindfulness based. But stress is so common, and stress is linked to depression and anxiety, of course. And I haven't had an opportunity yet to see what you had to say about anxiety, but stress, what I've come to learn, the verbiage is really nice, is how do you stress? Yeah. I mean, it's a great assessment question.
You wrote a book, too. I wrote a cookbook and published it.
Yeah, that's some good
stuff. This man writes a book about what he does.
Yeah, it's called Don't Let Your Emotions Run Your Life.
That's right.
How Dialectical Behavior Therapy Could Put You in Control, available at 8th Day Books in case you want to shop local in Wichita. I see we have some friends from Toronto and Arizona. You can order from them, or you can get it from the big guys who I don't need to name. Yeah. Okay, there's another commercial.
I need to get mine on 8th Day Books, because mine's only...
You do, you're a local
My book's
author.
Only available on Amazon.
You need to get some copies.
I need to get in Barnes & Noble.
Watermark.
Yeah.
Yeah, they do. They like to sell local authors. And I need that book.
And Jamie, did you know Jamie and I are coming out with a new book this year?
Jamie Farrell?
Yeah.
Oh.
And she's a therapist, or no, she's a social worker. Yeah. She's going to be working on her C.
Yeah.
But it's a book on eating your way out of anxiety and depression.
Okay.
And so we have 26 meals, a bunch of other kind of recipes, like auxiliary ones, so like salad dressings, that kind of stuff. But then talking about how those ingredients help your brain and help your body with anxiety and depression. So it's really good.
Great.
Yeah. So let's start with the easy thing. A lot of people go with genetics, but there are. So I looked this up. There's 44 what are called SNPs variants for this, and SNPs are single nucleotide polymorphisms. And basically,
just my hand gesture for what he's saying. I'm drawing it with my fingers.
What's that?
What you just said, the polymorph.
Single nucleotide polymorphism.
And he says he's not eloquent.
So you have now 20 to 25,000 genes in your body and your 6 foot of DNA. I have almost 25. I don't want to brag or make you think that I have so much more genetics than most people, but I do look down on people that have only 22,000 genes. I mean, can't get 23,000. So I think mine's 24,000 something.
Yeah.
Have you had yours done?
My what?
I bet you have like 27,000.
What do I?
Genes.
What do I have to do to find out?
You just do a 23andMe, and then we'll pull the raw data and then run it through software.
I did a ancestry thing.
Yeah, we'll pull it.
Okay.
We'll pull it. We'll figure it out.
Okay.
We'll see who has more genes.
I didn't realize I'd be called out on my gene count. Okay.
So most everybody goes with genetics, right? Because it's easier to just kind of like offset to that, because that allows you no responsibility to really say, did I do things that caused this? Do I have systems and habits and kind of like unhealthy boundaries that allow me to basically exhaust myself to the point where I'm anxious or depressed? I don't like that. But I will say, out of the 44 genetic mutations, like 44, that's not that many. Depression, just like anxiety, is a very multi-tiered process. So not only do you have to have the gene in the right place to be mutated, but it really is this gene plus this gene plus this gene plus this gene. Like the CRISPR gene technology, we're not going to fix depression with that or anxiety, because it's too many different genes that we're trying to mess with.
Yeah. Okay.
Whereas if someone has the methyl tetrahydrofolate reductase mutation, that's all the rage now, then they can...
I heard the kids talking about it on the way in. Kids out in the hallway.
If you saw the abbreviation for that, you hear it from kids on the bus. But you want me to write it for you?
No, I'm
right.
going to take some notes.
Okay.
In hopes that I can keep up with some things in case I have any commentary.
Yeah.
Or I might ask some follow-up questions.
So that's the research that me and Dr. Padilla are doing at KU Medical School with I think it's an NIH grant funded study that we're doing. So those kind of, like a methyl tetrahydrofolate reductase mutation, that's going to be a pretty profound reaction for people. Like, it's a one gene mechanism. There's 88 different variations, but it's kind of a one process, where anxiety and depression are multi-tiered. So when you look at statistics and you say, well, most all disease in America looks like this. It's low, and then we change something and create a sudden epidemic. If you look at genetics for countries, just like we looked at in the very beginning on, I think, the first one for anxiety and depression in America we're the number one in the world. In the world.
We're the best.
China is like half as anxious and depressed as Americans, and Europe is like very, very low, and Denmark's the happiest country in the world, right? So all these other countries still have jobs, they still have wives, they have divorces, they have kids, they have traffic. Denmark, they have more dark days and light days, right? Everything that we blame our depression, anxiety on, how are they so happy? And so it's not genetics. Only 1% of disease is genetics. 99% is what do you eat, drink, breathe, rub on your skin, and how do you stress, right?
How do you stress? So
we talked about how to eat your way into anxiety, which is obviously how to eat your way out of anxiety. We can drink ourselves into anxiety with high glycemic or high caffeinated things like a venti mocha should make you anxious all day, right? So if you get your blood sugar over 185, that'll actually stimulate epinephrine, norepinephrine when it overproduces insulin, and then you have anxiety.
Yeah.
Eventually you burn out and you get depression. But the treatment that we typically do at our office is not specific for any condition, really. It's just create normal and see what goes away. And I would say probably 95% of the time or better, everything goes away. The anxiety goes away, the depression goes away. Now, if someone's in real danger, like they're getting physically abused or they have like really traumatic kind of things going on in their lives, there's been a handful of those where it's just like, hey, this is not what we're doing here. You need to go see someone like Scott or Dr. Padilla or Mariah, right? You need to go see someone that they can unwrap this stuff, because that's not my stuff, right? So don't worry about the genetic part. Now, if you are treatment resistant for anxiety and depression, it would be worth doing a genetic test, and then you can come in here, we'll pull the raw data, we'll look at the 88 different variations of methyl tetrahydrofolate reductase, we'll look at all the genes, and then most of them are kind of like, you have a small predisposition for maybe anxiety and depression, which means you have to do all the other stuff we talk about more. You have to work harder. It's unfair, but happiness is still there, right? But for the methyl tetrahydrofolate reductase mutation pathways, if it's a C677T or a A1298C, I mean, that affects the bioterapin pathways, which affect memory, mood, brain function, thought processes, thyroid, sleep, and behaviors through the octopamine pathway. So that is one mutation that can seriously mess people up. And those are going to be the patients that medication doesn't work on, that therapy doesn't work on, that they've tried everything. And we see people go like night and day difference. Like even like bipolar kind of symptoms, manic stuff, if that's the thing, they should feel like that. It should be a nightmare to live like that. Now, someone like me, I have one of those mutations, but I feel perfectly fine. So, I'm okay. The treatment's super easy because you just do methyl tetrahydrofolate. So, you just have to bypass that receptor, and then you have to do epigenetics to try to fix it long term, but otherwise, it's pretty straightforward. So, hard to treat patients, that's a really good thing. So that genetic one is the rare genetic one. That's a problem.
Yeah.
Almost everything else is really just what are you doing to chronically cause a chronic problem? Because somehow people move here, their depression goes up, but they're still genetically the same. Americans are expats, their depression and anxiety goes way down, and genetically they didn't change, right? Most of your genetics are what are called phenotyping genetics or epigenetics.
Right.
And that is all regulated through what you do. Yes. Did you write that? Oh, he wrote epigenetics.
I was hoping we would
yes.
circle around the epigenetics.
So epigenetics is pretty interesting because I have something in my pocket. Oh.
Is it an epigenetic?
Yeah. Oh, I got coins.
Is it a telomere?
Look, I got coins.
Oh, okay.
I don't know why I have coins in my gold coins.
Whoa.
All right. So that bothers me. I don't know why. So with that, that's one part. I want to stop and say hi, Stephanie and Linda. Oh, Linda said she's moving to Denmark now. That's what I'm talking about. I got a patient that moved to Denmark, and she's like, it's totally different there. But she's also, I think, from Denmark, or her husband's from Denmark.
Okay.
And say hi to the Hastings.
Hello, Hastings.
So outside of like the epigenetic component, the rest of the stuff are things that are manageable things that we can do within our lifestyle, or dialectical kind of changes, or mindful changes. And one of the things I started doing with patients, because patients, I don't give a shit anymore. Like I'm gonna be who I am with patients. I'm just gonna say what I need to say. And patients are just like, yeah, I'm feeling awful and this and this. And like looking at what they're doing, I'm like, you should feel horrible. You are not living a lifestyle worth living. You should feel awful. And the real bad part about that is that there is survival of the fittest with your hormones and even your thyroid. Your thyroid will not convert T4 to T3 with chronic cortisol. It basically means if you cannot pull your shit together and find peace, you shouldn't be breathing, you shouldn't be thinking, you shouldn't be growing, you should just wither away and die. And that's messed up. But the goal of all this is to find that place that I never knew existed before meeting Scott, which is, what does a life worth living look like? And I tell you,
right.
Like I quote that with my patients all the time, because, and I'll tell you what. So I started like there's a handful of patients that are just kind of resistant, and they're just like really dug in with coping. And so I like wrote out this thing, like, what would a life worth living look like? What would you do differently when you eat? What would you do differently with movement? What would you do different? And it's probably like 10 little things
Mm-hmm.
And then what would your life look like differently in 3 months, 6 months, a year? And you know how long it takes before those patients actually get their homework done?
Tell me.
It's like 6 weeks.
Oh, hey,
Every time they're just like, I don't know how
bad.
to answer this.
Yeah. Yeah.
Because now most of my patients are women. 85% of healthcare is women. Men are selfish. We don't view self-care as selfish, so we'll do whatever the hell we want. If the world's falling apart, it'll be falling apart when I get back, right? So I'm going to go do what I want. Women tend to be martyrs. Moms are ultimate martyrs. Moms will give every drop of blood they have, feel guilty, laying on the floor that they don't have one more drop to give when they're dying. But who takes care of the martyr? No one. You should be depressed. You should be anxious in the beginning. You should fall apart, right? Stop being a martyr, right? Your kids are watching you to see what a life worth living looks like. How do a healthy person live? How does a woman with their own identity, their own happiness, live? How do they couple? How do they parent? And all like most parents do in America is basically just exhaust ourselves till we're anxious, multitask till we're anxious, exhaust till we're depressed, martyr ourselves, and then we feel like shit, and we should. So that I'm telling you, that thing, like, what is life worth living, like, resonated with me, because that's what, like, honestly, I feel like now, I used to think I was happy. Like, it is so different now. It is so different to have healthy boundaries. And those healthy boundaries don't always include family or friends or people that, like, were by your side, ride and die, but they're toxic for you. And it's a whole different world. I promise you guys, it's a whole different world if you do that hero's journey work, if you step across. And you need a mentor. And so there's people like Scott, there's people like me, there's other people. You be with someone that you vibe with that kind of holds your hand through that process. So, outside of genetics, how do you go from anxious and depressed in the most anxious and depressed country in the entire planet, where all your friends are anxious, all your people in church are anxious, all your people in your community, your doctor's anxious, everybody's trying to help you is just like dying inside. What are you going to do? All right, now Scott's turn to tell us what to do.
Well, my goodness. I'm going to piggyback on a little bit. I think we all know the soapbox, which is accurate. It's right on. And then and sometimes we don't catch how stressed we are because in a lot of ways what's that?
Soapbox?
Soapbox, something you stand on in the public square to give a speech you get preachy about. Yeah, kind of. It could be about politics or whatever. So, but that's a soapbox that I have definitely, and we're probably, our viewers are pretty aware of that. For some of us, that stress or that expression of stress, sense of busyness, those are badges of honor. Now, we're busy. Oh, we're so important. I'm busy. Man, you must be very important because you're very busy. And you go. And other people are anxious, and so we're probably even hitting some of our natural limits long before we really get clobbered by disease or profound depression or anxiety, because we're competing with others, because the norm is really exaggerated beyond that. So it's not that hard to kind of notice it at first because it just seems so normative. This is just what people do. We do these things. And do
you know Skinner's box?
Yeah, I do.
So I talk every consult. I talk about Skinner's box because patients come in. I'm sorry to cut you off, but this is important. So I'm getting on my soapbox. So most patients come in and they have that one thing that they can't seem to figure out themselves. They can't find their own happiness, and that's the one thing. So it could be Crohn's, it could be IBS, it could be eczema, it could be migraines, whatever it is, that's the one thing that they can no longer cope with. But Dr. Skinner did this experiment, and so people are Skinner boxing. I don't know if that's a real term, but that's what I tell
We're going to
people.
call it that.
So it took this room, divided the room into two sides, right and left, say A and B. He put electrodes on the A side with switch A, electrodes on the other side with switch B. And then he put a dog in here, because we're kind people, And now, if he turned on switch A, and no matter where that dog was on that side of the room, he's painfully shocked, but the other side was off, where's the dog go? He'd go to the off side, right?
Right.
The belief is we tend to choose happiness if we believe happiness is a choice. If I can fix or correct my own issues, I will. Not everybody will. Some people like to identify as disease, but usually they've kind of just become complacent. So now if the dog's over here on the floor that's off, I found my happiness. Switches off this side of the room, now switches on the half of the room that the dog's on, and now anywhere on this side he's being painfully shocked, but this side's off. Where's he go? So no tricks. He just goes back. He'll run around until he finds peace, right? But what happens if they turn on both sides? And now no matter where this dog goes, it's in constant pain and agony. And the most amazing thing happens. It just becomes normal. The dog, if you watch the dog, it's eating and sleeping. It'll sit. You would never know it's in constant pain and agony. And we all get really, really good at Skinner boxing. So I always give the example, like, you ask, like, hey, Mary, how you doing? Oh, I'm doing good. Yeah, I got the migraines once a month and the daily headaches, and I can't function without a pot of coffee in the morning, and I need energy drinks by the end of the day, and I still can't think straight, and I have severe brain fog. And, I pooped like every 3 days, and, I have a wrenching gut pain, but I'm doing pretty good.
Sounds great.
Do these sound like the people you know?
Some, yeah, some. Yeah.
That becomes the American phenomenon. We get really, really good and, like, noble about how I cope really well. Patients like, I tolerate pain. Why would you want to tolerate things very well? Like, why? Why? So Skinner boxing is that thing of, like, people get used to it, then they add on the next thing, then they add on the next thing, then they add on the next thing, and then it becomes this crippling depression. But like Scott was saying, is long before that, it was noticeable.
Yeah, if we're paying attention. So that's kind of that might be a nice place to kind of pivot toward. Just the whole idea about mindfulness as a practice to integrate into our daily lives, where we're becoming a little bit more aware, just little by little, just really paying attention to thoughts, feelings, bodily sensations, allowing our awareness, even how we're sitting in chairs, how our legs feel, what our posture's like. Even now, as I'm talking about it, I kind of feel like I should straighten up or do something. Got to do something, Patrick. And then also paying attention to, my body telling me, as it does tell us often, we live in bodies. It's saying you got to move. You were made for exercise, labor, gardening, something. We got to do something, but we're really in a lot of ways disconnected from that. And that's probably something we can touch on tonight, maybe, or even expound later in our super digitized, mentalized kind of life that we lead. Forget that we're in bodies. So it's important we take care of them, we exercise them. But just paying attention, we'll begin to notice, a slight ache, and that's the body giving us information, right? Hey, I need you to, don't use that back rest. Sit up. I need you to strengthen your core. I need you to stretch. I need you to stand up. I need you to move around, and so on. Or I need you to keep your head up a little more often than, nowadays we're doing a lot of this. Phones or even computers, if we haven't even worked at our workspace like this, and so on. So mindfulness helps us with that. This is really important from the standpoint also, some of the research I was doing in preparation and coming on tonight, it was really, I was looking for just some things I wanted to learn about depression, maybe I didn't know yet, but also something I think would be important for all of our viewers tonight. But you're touching on it a little bit, and then as a therapist, I do appreciate and try to read literature on neurobiology, neuroplasticity, all these sort of things, even epigenetics. And actually, this guy here has helped me learn a lot about that. I think that was one way we clicked, though, because I think I actually made a reference to epigenetics the first day you were there.
I nerded out on you.
So, and you were like, oh my gosh, this guy said epigenetics. I had him at epigenetics.
Yeah. You had me at epigenetics.
Yes. But it's interesting because when I work with clients who, you're talking about the willingness to be active and changing lifestyle, because DBT is so much about and even mindfulness-based therapy is really about inviting a client into an active lifestyle, and it doesn't mean pushing the envelope to be a super achiever or whatever, but to to almost return to almost a more kind of natural state of being as much as that's possible.
Yeah.
In our culture, such as it is, we do tend to internalize a lot. We get stuck in our skulls and we think and we mull over, and we analyze and we analyze and we analyze, and then and I think this is part of where we might get stuck in this stress, this excessive stress that we feel. As you know, Patrick, this is going to increase cortisol levels in the brain, and there's a very strong correlation between cortisol and a diminishment in hippocampal neurogenesis, and also causing atrophy of neurons in the brain, regardless of age. And so this is something that's really vital for all of us to know that as we experience stress by itself, I don't remember if this is if we're on the same page with this one or not. I think you're saying this. Stress is inevitable.
Right.
It's just stressful to be alive.
Stress is not what causes anxiety or depression.
No.
Not.
No, it's not.
This amount of stress makes you effective. I can do this and this and this and this, makes you anxious.
Right.
Yeah.
If I try to go beyond that, so it goes back to your assessment question, which I've really integrated that with my practices. How do you stress? I mean, how are you approaching it? How do you receive it? How do you dance with it? How do you, I guess that's the best way to put it, really.
Yeah.
So how can I be flexible with it and just, let it be what it is without adding to it, making it more than it actually is. And so it's important that I think we know this because I on occasion do have clients who do look a bit passive, that are kind of stuck in a particular way of seeing themselves as hopeless. Well, I can't exercise because I don't feel like it. I'm depressed. Right. That's why you have to exercise.
Right.
Because it'll counter the depression. In that kind of mindfulness framework, what's nice about that is this gives us so many layers where we just take the heat off. It's not about judging you. You're not lazy. You're not stupid. You're not like, you may be resisting, but there's a reason for that, and that is because we're humans, and so as the organisms that we are, we tend to be attracted to low effort, high reward activities. And then depending on a person's history, if a person has trauma in their history, or other like early attachment issues, or have experienced profound rejection or invalidation, these things affect neural pathways and emotion regulation systems, all that kind of thing. So there can be those sort of, I think, precursors to how this manifests as we become adults and what we do with our habits.
Yeah.
And so we want to link one of those dialectics in DBT, for example. It's really helpful, is saying you are as exactly as you should be presently. How can it be How can it be otherwise?
You are exactly. Say it again. This is way more elegant than. Yeah, your life should suck. Like
let's rewind it. Well, but it's
you said it so much better.
Well,
you're exactly where you should be.
How can it be otherwise? You're exactly where you should be, considering your biology, your history, and your current skill set, and the environment or context that you're in.
The skill set.
This is as good as you can do.
Yeah.
That's the best you can do.
Yeah.
And I'm going to share with everybody, and you, Patrick, the dialectical stitch. Dialectical stitch. It's because the dialectical stitch is that piece where we're saying, this is your present situation. And what a fundamental assumption about DBT is everybody's doing the best they can in any given circumstance.
Right.
So the alcoholic that's binge drinking because he's stressed out, stressing with alcohol, that's the best they can do. And everybody needs to do better, try harder, and be more motivated to change. And so, again, in that kind of mindfulness framework, inviting people to consider what do you perceive as what you really want in your life? What is a life worth living for you? And how are you, eating to be there? How are you breathing to be there? And how do you sit? How do you stand? How do you carry yourself? What are you? How are you relating to your internal world? Because something that can really exacerbate our feelings of stress, anxiety, and depression are we get latched onto thoughts, right? We get stuck. We get hooked, and we're just like really massage this. We ruminate over the past, or we ruminate about a catastrophic future, or and the catastrophes might be, you said white people problems. I'd say they're probably like they're kind of first world kinds of problems.
Yes.
Now, in all actuality,
first world problems.
All people suffer.
Yeah.
And it's we suffer for different reasons. Perhaps we think we suffer over different reasons, but a lot of the suffering that we do, a lot of the inordinate stress and anxiety and depression we experience, all of that's self-inflicted because of our habits we've accumulated over a lifetime. And so if you're 30, 40, or 50, and all of a sudden you kind of go, I don't feel real healthy, I need to do something about it, you're going to have to work really hard to change those neural pathways, the habits you've established, and so on. It's going to be a little bit more challenging in some ways to do that. And so it is important to do the dialectical stitch again is, this is the best I can do. I just ate 5 pounds of cookies before I went to bed. And I'm still moving forward.
Right.
I fall down and I get up.
Yeah.
And this is, I'm not proud of what I did, or this is less than what I value. Of course, another piece of DBT is, we're not going to get all of this, but it is the wise mind concept that, people are invited to cultivate their wisdom that everybody does have and knows how to live healthy when they're paying attention.
Right.
Okay. I'll be quiet for a minute.
No, so there's two things. And I got to say, like, when I first went to that mindful group that you're leading, I spent my whole goddamn life trying to hide the shame and the secrecy of all the poverty and abuse and trauma that I went through. And, like, you said something, I don't know. I was just like, I really had this just infantile belief that no one would know my pain. No one would know that shame, like I do. And like when I was in there, of course, we had all kinds of people that kind of cycled through the group, and then we had a core, Blue Waffler, what was it?
Sunshine Mafia.
Sunshine Mafia. Yeah, that was our the long termers. So people kept revealing, and like I was always that person. Like, I mean, again, I mentioned this last time. Like, how screwed up is it that at like 16 years old, some guy stuck a gun in my back? I didn't freak out whatsoever. I simply negotiated with him. He wanted my wallet. I'm just like, well, how about I give you the money out of my wallet and I keep my wallet? And like, you know how much trauma you have to go through to just be like, who cares you got a gun? Who cares it's pressed against my spine, you can blow me in half. Like, I'm going to negotiate this. Like, that's insane. That's an insane amount of, like, like, being desensitized to so much trauma. Yeah? Do you think so or no? Would you do it?
Oh, yeah.
You'd probably get them in therapy. Like,
just be like,
how was your childhood, man? Like,
Yeah. I don't know what I would do in that case in particular. But when we are exposed to chronic, those are stressors. We're exposed to violence or fear of violence or potential for bodily harm or death. That affects our, again, all that emotion regulation equipment that is biologically hardwired in us. And then we just kind of get used to it, after, certain, it's frog in a kettle. Yeah, we're kind of used to it. We're like, oh, well, it's just kind of what we do, and it makes sense again given we can say that's valid given your history.
Well, so one day there was somebody that was there. There was three of us. One used exercise as their addiction. When I was at my worst, was just using food because there's morphine and sugar's morphine, and or sugar's addictive as crack cocaine, but they all are for dopamine. So, and then there was a meth addict. And like, all of us were coping in different ways. And I never thought of myself as coping, right? I never thought anybody would understand my pain, my trauma, all that stuff. And one of the things, two of the things I want to touch on that, like you, like really impressed on me was being non-judgmental about it's just accepting. I can be angry, and it's okay to be angry. I can be upset or disappointed, and that's okay. And then the other thing is that sense of trauma is trauma, right? Oh, they wouldn't understand my trauma, and then when people have more trauma than me, but oh, you wouldn't understand my trauma.
Mm-hmm.
But trauma is just trauma. Like people all the time on Facebook is like, well, this girl just had this little problem. These people have real problems. Problems are problems. Trauma is trauma. And depression or anxiety from something you consider little trauma still is profound. As someone who's gotten used to a whole bunch of trauma and has a lot, it's the same. Yeah? Would you say that?
Yeah, and that, and also just kind of the general human condition for emotional suffering is such that it doesn't matter if you've got $1 million in the bank, or you're a privileged white male, as I am, or you're somebody who's struggling in poverty, or you've gotten caught up in drugs or some other addiction, or it's a food thing, or whatever
addiction.
it is. Again, it comes back to like here's something that would happen often in substance use treatment centers. Every now and then there would be a client that would ask me, are you in recovery, Scott? Meaning, are you doing AA or anything like that? Are you a former drug addict? I said, well, I did my field testing in the day, way back in the day. A little bit of field testing, but I'm not presently the 30s, because it was right around Prohibition. Because I'm a couple of days over 28.
You've always been like a father.
I know. You're a welcome son. I'm glad I could be there for you. And they would ask me that question, and some people were just curious, and I would say, well, I'm not in recovery, and then they're like, okay, just curious, just checking that out. But then some people might come back and say, as they would on occasion, say, well, then what gives you a qualification to assist us with our overcoming our addictions?
Yeah.
You're just going to throw some book stuff at us. And so I was aware of that, and I just somehow along the years kind of came to the place where I just said, well, I don't know what your struggle is, but I do know suffering. And so maybe whatever it is I'm battling or strapped with isn't
the same.
Doesn't make me a pariah the way it does you on a social scale, right? The difference between being a sugar addict versus being a heroin addict or meth addict, right? And then maybe that's led you down a path where you're on the lower rung of sort of social acceptance or approval, or because even in addictions there's a pecking order. The alcoholic wine aficionado is like, well, at least I'm not like those men who drink low shelf whiskey rock cut. And then those guys are the ones that say, well, at least I'm not doing heroin, and so on. So it's just like, but
right to heroin from alcohol?
Man, I'm like extreme. I'm trying to make a point.
Some rungs are missing on this ladder.
This ladder's all jacked up. Right down to suffering. But but that's the thing. We all know suffering.
Right. And
here's the thing: it's like also my DBT skills training groups, which I run. We got 8 or 10 people in there. And they run diagnostic gambit of meeting criteria for ADHD, borderline personality disorder. Different people have different levels and severities of trauma. And some people are there for anxiety. Some people don't have anything that's, really like, big and important, diagnostically, again, socially. But they don't like the way they relate to their emotions. So they're there to learn about that. And so sometimes it's interesting to hear them interact with each other, because somebody will come in and say, here's my situation. And then other people are like, oh, wow, I thought I had problems. Oh. But one thing that we all talk about as a group is, well, you do have some problems that you're facing in life. This is not a contest. You don't have to suffer more or less. It's whatever is stopping you from having the quality of life that you want, or to have a life worth living. That's the thing you need to work on. So, we don't have to be in a gutter to qualify as a candidate for therapy.
Yeah.
I hope all that made sense.
Yeah.
Yeah. Yeah. But I'm just noticing over here, I don't know what it means exactly when Linda said I do doggy paddles in my internal world. I don't know what it means, Linda.
Oh, coping.
Oh, the coping. Oh, I like it. Okay. Yeah, I like that. Doggy paddle, that's fabulous.
Yeah.
But yeah, so anyway, we all suffer differently. I mean, I'm sorry, we all suffer, period. And and here's the thing is, like, it doesn't, when we do the comparison thing, that's the automatic pilot. That's kind of the ingrained cultural thing. Better, more, less, um, qualified, not qualified.
That's qualifying.
Yeah.
That kind of like, you can't understand me because you're not qualified to understand my pain.
And also kind of came to that response through thinking through getting this. And I don't remember. I wish I remembered who, so I could give the proper attribution. But just in my experience in the substance abuse treatment centers, somebody bring up the points like, when I go to an oncologist, if I have cancer, and if I find out my oncologist doesn't have cancer, but they're the best one in the state, am I going to fire him? Probably not.
That's pretty good.
So there's also this kind of quality piece too, of just saying, look, I've got some training. It's not just books. I try to practice what I preach, but I'm gonna deliver you things I think that will make sense to you, and they work their principles, which means they work for everybody, but they can be customized so they can be nuanced to meet your needs where you're at. So it's not a cookie cutter.
I like that.
Yeah.
Yeah. Well, hey, we're running out of time. We still have tons to talk about.
My goodness, we have so much to talk about.
You want to come back next week? Can you do that?
Let me get back to you.
Right.
You know what? I'm not sure.
We could switch it to a Wednesday or something. Or not a Wednesday, but a Wednesday.
Let me check, because I'm giving 2 presentations in April.
Ooh, well,
I'm presenting at Newman, and I'm also presenting for a trauma treatment series, and I'm also part of a panel. It's not just me. There's some other fabulous folks there. And then I'm doing a brief 1-hour deal for the Kansas Adult Education Conference. So I just need to make sure I don't overdo it and stress myself out and become...
This is stressful?
This
is stressful?
This isn't stressful. This is great. But it'll be...
This is your love language.
I have a family now.
Oh, how dare you!
I'm
sorry.
My God! Did I mention that I'm married and I have a family now? I'm going to get my pipe out.
As someone who has someone that loves them every day.
Yes, as somebody who... but you have daughters, you have a family life too. So
this is why I love Scott.
I would love to, but let me check to make sure I don't commit beyond what I'm able to do without driving myself crazy or my family.
Okay. So hopefully we'll have Scott back on. We'll kind of figure out how to make it work, because he is just a absolute wealth of knowledge and my personal hero.
I hope I've been helpful.
Mm-hmm. You can't be handsome. You got to be handy.
So maybe we're both. Dialectic.
Handsome, handy, and helpful is my goal.
And healthy.
And healthy. Healthy, handy.
Healthy. This is a wise man conference we should have.
That's right.
Healthy, happy, handsome. Yeah.
Aw, that is sweet. I like that.
Yeah, pretty nice. Postcards.
So we need to get more in the meat of kind of like dialectical, mindful practices that people that are in the kind of midst of depression can work with. But
sure.
So I'd
love to do that. Yeah.
Even if we have to skip a week or something like that, we'll do a thing. But we'll come back to this, okay?
Yeah, let's talk. Let's strategize.
All right.
Because I would love to come back.
He's playing hard to get. He's like, oh, I don't know, Patrick. I got lots of other suitors that want my time and attention.
Patrick to value me. I just want to know that he values me.
You're not my only talk.
Yeah, I'm sorry. I have so many engagements.
And you have, do you still do your podcast?
No, I really haven't been doing that because of getting married in August, pandemic, and then we moved house right before Christmas. I have bought gear to do it, and I haven't made it happen, and I'm not blaming anybody, but the fact that I haven't given it.
You should judge yourself harshly on that. Harsh judgment. No,
not now. I'll probably judge myself when I get in the car and drive home.
Cry
all by myself. Eat a bag of tacos.
Into the arms of the woman that loves you.
Oh, yes, indeed.
I'll just go home to my cat, so,
Are the girls still living at home? What happened? They all grow up and go to college?
Well, one's in college, but, no, we split them.
Oh, okay. So, like right in half, right at the torso, or?
Yeah. So I keep the legs 1 week, and then, the whole thing. But they're all in their teenage years, so they're all locking themselves in their room and smell like teenagers and...
Even girls?
Yes.
Wow, okay.
They used to be all about me. They just do stuff. And then COVID, their mom's got them scared of COVID, so so they've been like, they don't want to go rock climbing, hiking, skating, like so. So poor Dad.
Well,
sad.
I go on the road trip stuff, but yeah, I'd like to come back so we can talk more about this. And you're inspiring me to get back on the bloggy bandwagon, which I also intend to do along with the podcasting.
Yeah.
Bloggy bandwagon.
And bring your genetics, so we'll go over them.
Oh man, I gotta look at. I'm scared. I'm not gonna have enough genetics.
I found out I'm 0.1% black, so my heritage started in Africa, and then went through Europe, and then to America.
Interesting.
Yeah.
I don't think mine. I almost want to redo it. I'm not disappointed, but I am especially English and Irish.
You look maybe like. Oh, you did your ancestry, so you know.
Yeah, but they don't. But there's some data they didn't have.
I feel like you're Celtic or something. Yeah.
Oh yeah, Irish.
You have a man skirt?
Picks.
I got a man skirt.
Do you?
Yeah.
The terry cloth robe.
I tried to look up the Irish plaid pattern for
tartan
for my family.
Yeah.
And
are you a Scotsman?
So the Irish do not have that. That's Scottish.
It's Scottish, right?
But Irish wear them. But Scottish are the ones that have the clan.
It's really a Scottish thing. It's a Scottish thing, so it is.
Ah, the bloody Scottish!
Oh my.
Right.
Now we're going to do really bad English accents.
Yeah. And
British accents.
All right.
Scottish.
For those of you guys watch offline, post your questions.
Yeah.
And then you guys are watching right now, post your questions.
Adam Heary, I love it. He says, bloggy bandwagon band name. He called it because he knows that I like to do band names. Hey, Adam, I got a band name for you. It's called Megan's Help. I haven't told Megan yet, but you know the Megan I'm talking about. So anyway, that's great.
How do they get a hold of you?
You can get a hold of me by emailing me at Scott, S-C-O-T-T.
What year is this? Emailing?
wisemindwiselife.com.
Is this AOL?
And you can visit me too on wisemindwiselife.com. It's my website. And the email is probably better for right now because I'm doing all telehealth and I don't really use a landline right now. So that's a good way to start. Or you can look me up on Facebook too. I don't have it memorized anymore. 260-1127.
If you Google Scott Spradlin.
And North Star or North Star Therapy.
Yeah.
You can find the phone number there.
Yeah.
Adam's watching. Maybe he can put the phone number in there for me. Could you be a good lad there, Adam, and put my phone number in for me? So let's start with the emails.
And we'll also, I want to talk about next time living in 3 time zones for anxiety and depression.
Oh,
that's one. So we might reiterate. I think we talked about the one-line theory too, of so you don't have to explode all the time when things don't go your way. Like, I love that. So, all right, you guys.
Cheerio.
Episode 191. This is our second part of depression. Hopefully, you guys are less depressed watching this.
Practice some meditation, exercise, eat some B vitamins, etc., so your hippocampus doesn't shrivel.
That's right.
We'll come back and talk about that some more.
And if you want that methyl tetrahydrofolate reductase mutation testing for the hard to treat stuff, let me know. Otherwise, if you're interested in dialectical behavioral therapy, you can go experience the SPRAD effect.
SPRAD factor.
SPRAD factor, dang it. All right.
But I have an effect on people.
All right.
Yeah. Thanks for having me on, man.
Yes, absolutely.
And thank you all for watching.
All right. Bye, you guys.